Good afternoon and welcome to the June 2022 board meeting of the Medicines and Healthcare Products Regulatory Agency held in public, or the MHRA as we prefer to call the agency. My name is Stephen Lightfoot and I'm the chair of the board, and my role today is to lead us through the agenda. So for those of you who've not attended one of our meetings before, I just need to start by saying that this is a board meeting held in public and it is not a public meeting. It's also important to explain that this board is responsible for agreeing the strategic direction of the agency, maintaining high standards of corporate governance, and also scrutinising the performance of the MHRA. But it's also important to say that this board does not make any regulatory decisions on medicines or medical devices. And that's because regulatory decisions are actually made on individual products. They're made by ministers, they're recommended by MHRA officials, who themselves are independent civil servants, with the additional independent advice from our expert advisory committees, such as the Commission on Human Medicines. I'd therefore like to emphasise that anyone who is involved in making regulatory decisions on medicinal products is not permitted to have any personal or direct interest in the pharmaceutical or the medical technology industry. Now, as far as today's meeting is concerned, I need to make you all aware that we'll be recording the meeting so we can publish the video on our website to provide the opportunity for as many people to see the work that the board does. I think on that particular note, I'm really pleased to say that we've got 67 people who are registered to observe our meeting today live, and that's including 33 people who are representing patients or patient groups. We've got 21 representatives from industry, 3 healthcare professionals, 1 journalist, and also 10 members of staff. So welcome to you all, and thank you very much for joining us this afternoon. Now, with introductions in mind, I'd like to go around the screen and just introduce my colleagues on the board so that the audience know who we all are. So as I said, my name is Stephen Lightfoot and I'm the chair of the board. I'd also like to therefore introduce Dame June Rain, who's the Chief Executive Officer of the agency. June, do you want to give us a wave if colleagues can see?
Good afternoon, everyone, and great to be here.
We've got Dr. Mark Bailey, who's our Chief Science, Research and Innovation Officer. You can give us a wave, Mark. Dr. Laura Squire, our Chief Healthcare Quality and Access Officer.
Good afternoon.
Dr. Alison Cave, who's actually abroad at the moment, but has been able to call in today, who's our Chief Safety Officer.
Good afternoon, everyone.
We've got Dr. Glenn Wells, our Chief Partnerships Officer.
Good afternoon.
We've got Joe Passingham, our Interim Chief Finance Officer.
Good afternoon.
And Claire Harrison, our Chief Technology Officer.
Good afternoon, everyone.
And then we've got our independent non-executive directors. So there's Dr. Junaid Bajwa.
Afternoon, everyone.
Mandy Calvert.
Afternoon, everyone.
Professor Graham Cook.
Afternoon, everyone.
We've got Dr. Paul Goldsmith.
Good afternoon.
We've got Haider Hussain.
Good afternoon.
Mercy Jessingham.
Good afternoon.
And Michael Whitehouse.
Good afternoon.
And I'm also pleased to say that we're joined today by Carly McGurry, our Director of Governance.
Hello, everyone.
We've got Natalie Richards, our Head of the Executive Officer, who'll be taking today's notes.
Hello.
And we've got Catherine Glover, the Deputy Director for Medicines and Prescribing at the Department of Health and Social Care. So you should all have access to our board pack of the papers for today's meeting, and I'll use the page numbers in that pack to keep us all on track. I will also assume that everyone has read the papers so that we can spend most of our time today on discussion rather than presentation of the items to be discussed. Now, although this is not a public meeting, we will provide an opportunity for members of the public to ask questions on any items on the agenda, and this can be done using the chat function through Zoom. Our Director of Governance, Carly McGurry, will then collate these questions and we'll answer as many of them as we can in the question and answer session at the end of the meeting. And also, if there are any questions that are not related to the agenda, we'll actually take those away and we'll actually send a response in writing after the meeting so that we can focus today's discussion around the topics that are on today's agenda. So that's all I wanted to say by way of introduction. Carly, can I just check, have I missed anything or is there anything else that we need to add?
No, I think that's fine. Thank you, Steve.
Great. Okay. Right, well, thank you very much for that. So that's really the purpose of the meeting. So we've got a number of items on the agenda, very much related to the coming up to the year end. So there's a number of important governance items which we'll discuss. So we've gone through the introductions. There are a couple of absences which we just need to note in the minutes, please. So Raj Long, one of our non-executive directors, is actually ill, unfortunately, so isn't able to join us today. We've also had apologies from Alison Strath, the Chief Pharmaceutical Officer in Scotland, from Greg Chalmers, who's the head of the Chief Medical Officer's Office Policy Division in Scotland, and also I think Kathy Harrison was hoping to join, but I think may not be able to join just yet. So she's the Chief Pharmaceutical Officer from Northern Ireland. So I think with that as the introductions, the important point of the agenda now is just to move on to declarations of interest. And if we move to page number 3, you can see there's a current list of declarations, but I know that there's a number of new ones. So if I can maybe just call colleagues to declare any new declarations of interest. So Junaid, I think you've got one you'd like to mention.
Thanks, Stephen. So just for everybody's awareness, I've been asked to join the board of DIA Global, which is a global not-for-profit organization aiming to accelerate innovation across all ecosystems involved in healthcare. And it's an organization which I believe the MHRA has had good working relationships in the past. So delighted to be on their board.
Great. Okay, well, that one is noted and is included in the register. Ada, I think you have one as well.
Thanks, Stephen. I'm delighted to say I've been appointed to the board of the Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board as an associate non-exec member.
And that's an NHS organisation, Ada, isn't it? So
yes, indeed.
Thank you for that. And Mercy, I think you've got a similar one.
I have, so just continuing that, I'm a non-executive member for South West London Integrated Care Board, starting on the 1st of July.
Excellent. Thank you, Mercy. Also, just for colleagues to know, Raj would have declared, had she been here, that she's been appointed as an associate non-executive director for the UK Health Security Agency, UKHSA. And I think, Graham, I think you've got a declaration about an item on today's agenda.
Yeah, just in relation to the later agenda, I'm involved in some of the discussions around access to tecovirimat for monkeypox in the UK and potential academic clinical trials of that.
Okay, but that's actually, and that's relevant because that's mentioned in the Chief Executive's report, I believe, isn't it? So, so having considered the declarations in advance, then at this stage, I don't think there are any conflicts that would mean that we'd need to ask anyone to leave the meeting. But can I just check if there are any other declarations that have not been mentioned so far or not on the register of interest, just for completeness? No, can't see any hands up. So, okay, I think on that basis, I don't believe we need to ask anyone to leave the meeting for any of the items. Can I just check if everyone's content with that as an approach? Okay, I'll take that as consent. So we'll just note that in the minutes, please. So those new declarations, Natalie, and also the fact that actually there's no objection to us continuing as we are present. That being the case, then let's move on to page number 7 in the board pack, and that's the minutes of the last meeting. Can I just check first of all, are they a true and accurate record of the meeting? I'm not seeing any hands up. I in fact spotted an error of my own actually, and that's the fact that there are no apologies from Glenn Wells. So Glenn, I know you weren't able to be at the last meeting, and we seem to have omitted the apologies from you, which I know that you sent in advance because it was a long-standing engagement that you had. So I think, Natalie, if we can just correct the minutes to include apologies from Glenn from the last meeting, that will be helpful. But I think with that small change, if we can then take those actions as an accurate record of the meeting, then we can approve those on behalf of the board. I think, yep, not seeing any objections to that, so we'll approve the minutes of the last meeting. If we then just move on to page number 13, which is obviously the actions action log, and I'd just like to focus first of all really on the actions in red, which are due today. So action number 58 is an update of what's called the framework agreement between the MHRA and the Department of Health and Social Care. That's on the agenda this afternoon, so I think we can pick that one up at that particular point. Item number 65 is marked down as completed, so I think the Patient Safety Engagement Committee has actually considered risking patients and will continue to do so on an ongoing basis. But I think it's fair to say, Mercy, that action can be closed. Item number 75 is then providing details of agency's reverse mentoring scheme to board directors. And actually, I'm really pleased with this, actually. I got an update yesterday. There were 33 applications from members of staff to act as reverse mentors. And so far, 26 managers, including myself, have volunteered to be mentored or to be the mentees for this reverse mentoring scheme. The matching is ongoing at the moment, and we'll be able to start the programme hopefully in July. And at that point, we'll be able to sort of start to sort of gain the benefit of understanding what it's like working in the agency from another person's point of view, more junior in the organisation. So personally, I'm really looking forward to getting some really valuable insight from that. Now, we obviously only have 26 managers and there's 33 members of staff. So if any members of the board would still like to be involved, then can you please contact Sarah Tyler. But I think in terms of the action itself has been completed, the programme of work will continue in the months to come. And I'm sure we'll hear back around about that when we talk about the people strategy in due course. Item number 76 was around monthly financial income and expenditure reports versus budget. John Fundry, the previous Chief Operating Officer, confirmed that that was going to be done. Can I just check with Joe that actually we are providing financial income and expenditure data to all the cost centre managers through the agency in practice?
Yeah, we've had, with April being the first year of the month and year end, so it's been a bit of a struggle for April. But yes, as John stated, it is the intention to produce those reports, even though manually currently, to enable leaders to make the right decision.
Yeah, and then obviously we'll automate that over in due course with our technology investments. So, okay, that's great. So again, I think we can mark 76 down as completed as well. And number 77 was about sending written responses to the observers from the February board meeting. I know that's been completed. Number 78 was about a question that came up in April, actually, around whether complaints escalated to the Parliamentary Ombudsman should be reported to the board. Rachel Bosworth, our Director of Communications, is not here today, unfortunately. So, Carly, I just wondered if there's any insight you could provide on that particular action?
Yes, happy to. As complaints of a stage 2 nature and referrals to the Parliamentary and Health Ombudsman would fall under the remit of governance anyway, so it's kind of a two-part responsibility. So a couple of data points. We have had no cases considered by the Public Health Ombudsman over the last 5 years. There were 2 referrals made in 18-19, but they were outside of the Ombudsman's remit. 1 referral has been made this year, but the Ombudsman is yet to rule on whether they will be taking that forward. As I say, these referrals come out of people who are dissatisfied with how their stage 2 administrative complaint has been handled. Just for the board's understanding, we've had 3 stage 2 cases so far this year. We had 3 last year and 1 the year before. I've discussed this briefly with Michael, and we think what might be a more appropriate way forward is for a report on these cases, along with our wider pool of stage 1 complaints, to go to ARAC, which already receives a lot of reports on associated issues such as speaking up issues from within the organisation, and that would enable ARAC to look at them in their broader context, and ARAC then of course can advise the board as necessary in its assurance reports.
Yeah, and just for the benefit of the public, ARAC is the Audit Risk and Risk Assurance Committee. Thank you for that. I think that seems like a very sensible proposal. Michael, can I just double check that you're content with that as an approach?
Yes, indeed, Stephen. Yes, very much so.
And can I just check the board is content with that as an approach? Yeah, I've seen nodding heads. So on that basis then, let's make that a clear action, Natalie, please, that a report on any complaints, stage 1 and stage 2, as Carly's described, will go to the Audit and Risk Assurance Committee. So I think we can close that action down as well with that as the intent. Thank you very much for that. In terms of just finishing off the last few actions, item number 81 was a change to the way we're handling questions from the public. That has been completed because that's the way we're approaching it at the last meeting and also this meeting. So we'll basically, in summary, we will take questions during the meeting from members of the public on items relating to the agenda and any other questions that are raised either in advance or during the meeting that are not related to the agenda, we'll handle in writing. And then finally, on that very point, number 82, there were a number of written questions actually we received that weren't related to the agenda. And actually, I just wanted to check with June that actually all of those individual members of the public got a response.
Yes, Chair can confirm they all did.
That's great. So again, on that basis, then Natalie, we can close down action number 82 as well. So, okay, so thank you for just taking the time just to go through the actions that were due today. Can I just check if there were any other matters arising from the last meeting in April? Not seeing any hands. So on that basis, then I think we'll move swiftly on. So thank you for your time on that. So in terms of the first item on the agenda, this is around agency performance and in particular how much of our MHRA delivery plan was delivered in the first year, the first of 2 years in 2021-22. So June, again, you can assume that we've read the report, but are there any introductory comments you'd like to make by way of introduction?
Yes, I think I'd like to say that clearly this report represents the work of everybody on the line here, the chief officers and directors, all the executive team, as well as many, many staff across the agency. We knew last year when we adopted it that it would be an ambitious plan. We're now halfway through. And it's really good to be able to say the majority of deliverables due in the first year have been delivered. And it's a nice point to say, yes, we have our new agency, new structure in place that places patients at the heart of all our activities. And we've published for the first time a patient involvement strategy. We've now got the development of new services underway, and we're working particularly on our new access pathway with health technology assessment and other international regulatory authorities. So our new, if you like, efforts are well in hand. Our new safety and surveillance system, Safety Connect, is beginning to roll out so that patients have a better experience reporting safety issues, just as the Cumberledge report recommended. And we've got important proposals for regulatory reform in key areas. And we have a sustainable business model for the next year, and we're well advanced with our new fees policy. It's worth saying these things because it leads up to an open and honest admission that there has been slippage in some areas. 15 deliverables have got revised due dates. And I think everyone on the line knows that there have been workload pressures that has impacted capacity, especially for some strategic deliverables. We've taken longer than we hoped to get staff into new roles in our new structure. And of course, during the whole year, we've prioritised COVID work. So there are some important reasons. The paper touches on 3 important areas where the board, I know, will want to focus. We had an original deliverable around the new digital self-service platform, but that's going to be wrapped up in an alternative way forward, our risk regulatory management system. The valproate registry, again, a really important area of work, but colleagues will be aware that the Commission on Human Medicines is now looking again at risk and minimisation measures. And then last but not least, the devices transparency scheme, which of course we'll be coming back to in the context of the data strategy and the new legislation. So it's important to highlight those because they are important. And at the Executive Committee, we're giving very rigorous scrutiny to those rescheduled deliverables. I think overall, Chair, I want the board to note on behalf of everyone on the line that it's good that the first year is in a good position in terms of delivery. Much of what we set out to do has been done. As with any year's work, things happen along the way, but the adjusted timeframes that you'll see in the annexes are going to be monitored very rigorously. So over to the board for further discussion. And of course, just this morning, we looked at what the next year will have as its priorities, really substantial deliverables for patient involvement, priorities in terms of equity in healthcare, and some key expansion of our transformation not that we're saying that now, but a focus on leadership for our new organisation, financial sustainability, and an ability to grow and prosper in areas where new opportunities come up. So over to the board to discuss.
That's great. Well, thank you, June. I think it's really important that we probably start with a thank you, actually, because actually the context around this is we always knew that the transformation of the agency was going to be at least a 2-year programme. And on that basis, we put the 2-year delivery plan together, and it was ambitious. You know, there's a lot of moving parts in this. So I think it's really important to say thank you for all the effort that has been done. It's been a team effort, and I know that's been the case. So I think we should just record the board's thanks as first of all in the minutes, please, Natalie, if that's okay. So colleagues, any particular questions that anyone would like to raise? So Mercy.
Yes, I just want to ask about the extension of the registry UK-wide, and really how we link into GPs and publicity. And I think we're also developing a health professional strategy and how that might link as well. I know specifically we're looking about the operate registry, but in general terms, how we kind of link into GPs. So June or anyone, if they could answer that.
Yes, Alison may well be listening in and want to go into more detail. Aspects of that extension plan may well be affected by new advice that the Commission on Human Medicines is cogitating and thinking through. So it's not by way of deferring what is absolutely a really important programme, but we need to get that further emphasis and guidance in terms of the plan. So we hope to accelerate once we have that, and indeed to engage with the companies themselves who are going to be subject to any new requirements that are implemented. And I'd like to see if Alison would like to add more detail there.
Yes, no, I'm happy to add a little bit more detail. I mean, the Valparate registry already extracts data. I'm hearing a bit of an echo, apologies. Already extracts data from GP records. So it is extracting data from the record passively and then linking with other data to maternity services and etc. So is that what you were asking, Mercy? Whether
it's really about I mean, that's part of it, that's part of the picture, but it's really publicity to GPs. You know, how well aware are they of this, and how much do we kind of raise awareness amongst them?
Yes, I think we could do more in that space, and we will wait to hear what the Commission on Human Medicines recommends, because currently it is extracted from the record rather than a conscious registration.
Okay, so it sounds like
you anticipate more action in this space.
Yes, Alison's kind of emphasising how we need to rethink where we are. It served us really well and provided very important data on the ongoing exposure of pregnancies. But now I think in terms of perhaps on the basis of that data, looking at a different and strengthened approach, particularly as Mercy's saying, connecting GPs in, who are the key people in the patient journey. Stephen, Mercy had a second question around our strategy for engaging more and better with healthcare professionals. It has been to the Patient Safety Engagement Committee a couple of times, and it's now ready to come back again for rollout consultation.
Okay, so that's excellent. Thank you for that. So Hader, I think you were next.
Thank you, Stephen. I'd just like to echo your thanks to the whole team at the MHRA for all the hard work they've done, significant reduction in unblocking all the off-track deliverables. I think there's been some really, really great work there. My question was really around the work package for AI that I was trying to make sure I understood the update for, which states the roadmap with deliverables will be progressing to clearances in April. Do we know if this happened? And if so, are we on track to turn this back to green by the end of this quarter, or is it by the end of next quarter? I'm not sure if
maybe I can
Alison.
Yeah, I'm happy to come in on that. Hader, that is sitting behind the results of the consultation, so it needs to follow it. So I think unfortunately it's therefore tracking it. So we are ready, we have the work plan there and ready to go, but it's sitting behind it. So as soon as we've moved those two deliverables actually sit together. So once we move the other, then yes, absolutely on track to get back on track with both of them.
Brilliant, thank you, Laura.
It's probably important just to recognise a government decision of when to make the announcements on the device consultation. So it's out of our control, but we'll clearly respond with the actions that are in our control as soon as that announcement has been made by the government. Mandy, can I come to you next, please?
Yes. Echo what everybody said, and I think a huge amount of work has been done on recruitment and getting people into new positions. Just wanted to ask a question around what do you think we've learned from this first year of the delivery plan that we can enable us to accelerate the delivery of the important items for the second year, as we've got some really important digital items to implement, particularly RMS. So what learning have we taken from the first year, and how are we going to accelerate that delivery, particularly of the RMS platform?
Yeah, and just for the members of the benefit of the members of the public, RMS is the regulatory management system, a new technology platform for us to actually basically operate the agency on. So June, maybe any lessons learned and reflections on what we've learned from this first year?
Well, with such an ambitious delivery plan, it is relentless prioritisation, and being aware of the interdependencies, which there are quite significant ones. I think we probably are quite detailed in our minds and process oriented, and that's when looking at what outcome we want to see and what success looks like is absolutely vital. So that's one big area of learning. And then I think it's that ability to try and work together in a way that we see each other's problems and find solutions for one another. Inevitably, any very large organisation can sink back into silos. The beauty of an integrated one agency delivering for patients is that we've eliminated silos in a very purposeful way. But even so, it's I think in terms of particularly on the offering opportunities to staff, it was seeing a whole agency picture, and in that way helping to look to building careers for our talented staff. So there's just a couple of thoughts, and I think there's going to have to be a good exercise to learn some of those lessons so as not to repeat them.
Yeah, I think that's a really helpful, thoughtful question, Mandy, actually, because I think we do need to keep iterating, because obviously we've got year 2 for this delivery plan, and then we'll continue with wanting to continue to adapt and be relevant to the patients and the the industry that we serve. So it's important that we keep learning, I think it's fair to say. So thank you for that. Michael, can I just bring you in, please?
Yeah, thank you, Stephen. And again, I echo everybody's comments. This is very impressive. So I've got an observation which probably builds very much on Mandy's point, and then a question. If you look under financial sustainability, particularly items 52 and 58, which relate to the overhaul of costly legacy systems and to deliver the RMS system by Q1, we've gone over the year from a red rating to an amber to a green in both of those, which is excellent. I just asked the question, is it really green? Because implementing this, some of these changes are not without their challenges. And I just question whether we're not at risk of optimism bias here, because there are a number of hurdles. I'm not trying to take on an executive role here, but it's very much about challenging whether we've got that assessment right, and it very much builds on Mandy's point. And then my second point, June, is this. Again, I commend your personal commitment to implementing Cumberledge, and I think looking at the ratings in this delivery plan, a number of the components that are part of our response to Cumberledge have progressed from red, amber to green. I just welcome your assessment at the moment. Are you happy where we are in relation to implementing Cumberledge and the vision that she had? So 2 questions from me, Stephen, on completely different things.
Yeah, 2 very different things. So maybe I'll bring Claire in first, if that's okay, just in terms of your satisfaction on the technology platform improvements. What gives you confidence that the ratings are correct, Claire?
I think one of the reasons is because of the lessons learned. So that was one of the questions that was posed. And from my perspective, June had covered or touched upon a few, but just in a couple of bullets. One, being laser focused on delivery and really sharpening our focus and our prioritization. So instead of trying to do many things not very well, it would be the half a dozen things and so on, and all of the and those being the priorities of all the organisation. I think the other thing as well is having that holistic view of digital data and technology across the organisation, rather than through the lens of, say, a vehicle such as programs and projects. So thinking about the capabilities that are being delivered and then sustained and supported going forward across the whole of the agency, rather than a start date of a project and then a stop date. And the other thing is, and this does not mean cutting corners, just being leaner with everything, and again working together as an agency team. So that could be governance, it could be all of those things, being leaner but not cutting any corners. So I think it's achieving that balance. And just the last thing I would say, I'm working really hard to try and stop the sort of, as pedantic as it sounds, a separation seemingly of the business and IT, because digital data and technology are part of the business. So again, it's that mindset about all of us working towards common goals and on the same priorities as one agency team.
Okay, thank you, Claire.
I think that's very helpful context, actually, Claire, and I think that provides a lot of reassurance. I think there'll also be some assurance reports that will come to your committee, Michael, I would imagine, in terms of your committee schedule will include some hard facts in terms of the assurance reports on some of the deliverables around technology platform, I would imagine, because they're significant investments. And similarly, Mandy, I suspect, on the Organisational Development and Remuneration Committee, we know technology is a real enabler. So in that sense, I think actually, as we're looking as the organisation grows and develops, again, I think I'm sure your committee will also keep a different perspective on the implementation of technology.
I think that's another thing, if I can just quickly come in there, Stephen, the working in the open, as I call it. So yes, the committees and the support and guidance and steer that we get from those, they're really helpful. But also there's a term in digital called showing the thing, and not necessarily in a formal way, show and tells, lunch and learns and so on, that constant communication and keeping that momentum so we all see what we're getting, and that sort of complements those committees as well. So that's another thing that we'll see a lot more of.
Good. Okay, well, I think that's very helpful. June, can I come to you maybe first in terms of, Michael, just ask for your sort of perspective around the progress with college, and we might want to bring Alison into the conversation as well in a moment.
College report asked us to recommended us to overhaul our safety systems. And we've interpreted 3 pillars or areas of work. One is patient involvement. One is our safety vigilance capability, technically, the signal detection. And one is the ability to have better evidence. And we've pushed forward on all of those 3. As you'll see later in the papers, when we talk about the progress on Safety Connect, it's now delivering. It's not totally there, and it won't be for several more months, but we're beginning to have a responsive system in place that enables patients to report and have a much better experience interacting with us. And that really mattered to the patient groups that were involved with Cumberledge. In terms of patient involvement, we have our patient involvement strategy. And as we discussed earlier, we're going to be looking at some very meaningful deliverables there. And then last of all, we had our data strategy beginning after our seminar last month to look at better use of real world evidence to contextualize safety signals. Stephen, Michael's question is a very good one, because I've already referred to valproate. When new evidence comes up, we have to be ready to rethink. And I think your point about, is it truly green, until we properly address the risks of using valproate in women of childbearing potential, I don't think it will be green. A system change isn't enough unless those systems work for patients. So rest assured, we're keeping an eagle eye on this, particularly as we come up to the 8th of July, when the government's response will be published.
Thank you.
Okay, thank you for that, June. Claire, you did have your hand up earlier. We wanted to make a point of your own earlier or not?
Sorry, was that to me?
Yes, you had your hand up earlier.
Yeah, the only thing I would add to that is, and that again, assurance and confidence around being on track for delivery, all the things that I've mentioned, but that really close collaboration with users and business. So understanding user needs, business needs, our customers. So that's internal users, it's industry, it's patients, and all the representatives of those. So again, the things that we're delivering in the digital and technology space, and that's encompassed in our data strategy, are hitting the spot. We're looking at the right things and delivering the right things in the right order.
Okay. Well, thank you for that. So the agenda question was how much of the MHRA delivery plan was delivered in the first year. I think from reading the report and listening to the conversation, I think the majority of the delivery plan has been achieved, which I think is a remarkable, and significant and notable point to put into the minutes. I think actually I'm also assured personally that there's a very clear action plan to actually bring the items that were delayed back on track. And we've started to unpick some of that during the discussion too. So I think it's all to play for in year 2. So, that will, if you like, complete our transformation. And then it's a case of how we continue to evolve and to grow and to change with new technologies and inevitably new opportunities with legislation outside of Europe too. So I think on that particular point, we're asked to note the report for assurance. So unless there are any other questions, Natalie, we can note the report for assurance. Thank you very much. So the next item on the agenda is an assurance item. This is all part of our preparation for our financial year end, which in the public sector obviously is the 31st of March of each year. So we've just been putting all the different components together. So the next items are related in terms of an assurance report from our Audit and Risk Assurance Committee. We've got some draft financial results from our finance team, and then there's also from the governance team an update on the annual report. So these items are linked. But Michael, do you want to start with any assurance you can provide from the Audit and Risk Assurance Committee?
Yes, thank you, Stephen. The Audit and Risk Assurance Committee, we met in May, and you have the report for me and my colleagues on that meeting, and we met again yesterday. What I'm going to focus on is the financial statements and where we are on the external audit, because I think that's the key item of the moment. So for colleagues, just to remind colleagues and for members of the public and stakeholders listening, we are an agency of government. We are required under the legislation to formally present our annual report and financial statements to Parliament, the House of Commons, before Parliament goes into its summer recess. And that usually is around about the 3rd week in July. So Parliament will probably rise as around about the 21st of July. And that's the drop dead date when we have to make sure that we have got audited financial statements and annual reports presented to them. Now, we have a very clear timetable to deliver on that, and ARAC, the Audit Committee, considered the external audit report yesterday, as well as the draft financial statements and annual report. And I'm not going to comment on the financial statements and annual report because they're the next items on the board agenda. Where we are with external audit, they have done the substantive work that they need to do to form their audit opinion. There is nothing fundamental that has arisen as yet. They have, however, encountered a number of errors in their sampling, which means that to ensure that they comply with the standards that they operate to, they have to do some additional work. I have to give assurance to the board that none of these errors have led to any material adjustment required on the face of the account. So the account that's presented to us today, and we'll consider shortly, is as good as we're going to get at this point in time. Now, external audit need probably a further 5 days to complete their work, and there are some outstanding issues where the agency needs to get formal approval from the Treasury. None of this should raise concerns. We're just going through the appropriate processes. So at this point in time, Stephen, as we've done in previous years, I would be asking under the next item for the board to consider and approve the financial statements in principle. I would ask that you and board colleagues would delegate to me responsibility to keep in contact with finance and June as accounting officer and our external auditors, and notify the board at the point in time at which the audit work has been completed and that a formal audit opinion has been issued. I envisage that will be sometime over the next 2 to 2.5 weeks. That's still within the timetable for ensuring that we deliver the accounts as audited to Parliament. Of course, if in this remaining work that has to be undertaken, it should result in any material adjustment in the financial statements as presented to the board today, I would obviously come back to you and say that I think it would be appropriate to reconvene the board to look at the implications of that. But I have no indication to say that that is the likelihood. I think that's all I want to say at this point in time. We did everything else that we are required to do yesterday in terms of considering the internal audits reports and the annual assurance from the head of internal audit. We are learning the lessons from that, and I am very pleased to say and would commend the agency, because in the annual report and the governance statement that forms part of the annual report, the agency has been very transparent in setting out things that have gone well this year, but equally things that might have gone better, and have also highlighted what they are doing to secure improvements and to learn the lessons. So I would commend the agency for that. And the other thing is, we're not there yet, but I am very conscious of the very hard work that Rose, Deputy Director of Finance, Joe, Director of Finance, and Salim, Chief Accountant, and his team have invested in this process over the last couple of weeks. It's not easy, and I do very much thank them for what they've done. I hope that gives a fair assessment of where we are at this point in time.
Okay, well, thank you for that, Michael. So I think what we should probably do is not make a decision on your proposal to delegate authority until we've actually discussed the financial accounts, and then I'll come back to that proposal after the next item, if that's okay. But I think your proposal is very clear. I think your explanation is very clear. But let's go to questions. Mercy, I think you wanted to raise a point.
I did, actually. It was really about your point in 4.3, Michael, which was looking at the culture of the organisation and the need to kind of delegate decision making further down. And it's really more comments than anything else about how difficult it is in a regulatory organisation, which has to be quite risk averse, to take have that shift in culture where we're more tolerant to risk, because obviously trying to get people to take decisions kind of further down the organisation, we need to have their back and have a learning and not a blame culture. But I also realise that's quite a difficult thing to achieve. So it really was a comment, unless Michael, you wanted to come back on that.
No, Mercy, I think it's a very good observation, and you know, a lot of my career was in external audit within the National Audit Office, and we had exactly the same problem, and it manifested itself in a way that we were constantly I'd say, berated by the Treasury and the centre of government that was saying we were risk averse, and we ended up creating a risk averse culture within Whitehall. So I think there is the way I tried to tackle it, and the team that I work with at senior levels within the NEO, is it's about instilling confidence in people within the organisation that they can take decisions, and not losing sight of the fundamental founding principle, which I think is very strong in the MHRA, is that we're an evidence-based organisation. But actually, when you're looking at evidence, it has to be proportionate. You can't, go on and on and on analysing the evidence until you feel happy. You do have to adopt a more risk-averse approach. I think what we were focusing on there was much more decision-making in the corporate sphere, where I think sometimes we haven't necessarily, as an agency, always got it right. But I think it's part of the wider cultural change that June and colleagues are leading on that. But it's a very good point, and thank you for your comment.
Yeah, I think the most important point there, actually, Mercy and Michael, actually, is risk proportionality. So what we don't want to do is to take risks on things that have got significant, sort of safety implications. I think is fundamental to say, and I think actually at other levels we can actually take a sort of a more appropriate approach. But June, I know this is something that's very close to your heart. Is there anything else that you want to add, just in terms of culture and decision making within the agency from an executive point of view?
Simply that in our one agency leadership group, it's something that we've prioritised to get working on together, and we're meeting monthly now. I think it might even be in the next month that we're going to start to really think this through, so that the messaging around it isn't ambiguous, and that people will be supported to make decisions. There'll obviously need to be appropriate training in particular areas, but that's as taken as read.
Okay, that's great. Thank you for that, Mercy. Mandy, you had a question.
It was really just adding to what June and Mercy said from an ODRC perspective on the culture, and we're very conscious of the internal audit on culture, and how we're putting the governance structure together, and clarity on roles and responsibilities as a key part of the framework, and conscious that there are many things happening at the same time. And so we've had we've been concentrating on getting people appointed into the new roles, and I think it's only over the last month or so that's started to really fill, which is then going to enable the cultural change to really accelerate, because you've got the people in place, and it is a lot about people and leadership, and with the theory isn't going to really work without having the people there and to start making that happen. So we are very conscious of that and keeping a track on that also at ODRC, as well as obviously this has got a key part for ARAC as well to monitor.
Yeah. And ODRC being the Organisational Development Remuneration Committee, and I think it is important that we do have. It's really important that we do have strong governance, we have clear process, and we have just clear levels of decision-making responsibility. So I think actually, as long as we've got that very clear framework to operate in, then I think we need to enable that freedom to operate within those appropriately and proportionate limits that we provide. So that's certainly the intention. Okay, so I think on that basis, Michael, we'll come back to your proposal after the next item, if that's okay. But I think in terms of the assurance report itself, can I suggest that we note that for assurance in the minutes, please? Yep, okay, that looks okay. So that being the case, then let's move on to the next item, which is, if you like, the draft financial results. These clearly are still subject to audit, but I think it's important for the board to see what the current look is, it currently looks like. So Joe, do you want to just give us an overview of the finances? So that'll be from page 34 in the board pack.
Of course, thank you, Stephen. So both the annual report and accounts and the separate paper presented to the board sets out the financial year for 21-22. And as noted, it's draft, but we don't anticipate any significant changes. I've just add a little to the report to bring a bit more detail to the board. So trading income did see a slight overall increase of 2.6%. This actually masks the fact that we achieved a really strong performance operationally across all the operating groups, with notable increases of service fees and standards in NIBs. This mitigated the loss of financial assistance that we've previously been getting from DHSC post exit from the EU. So there is a really strong trading performance, if you like, within the numbers. Staff costs obviously are our most significant cost. Year on year, we saw a net decrease of 1.6%. However, I would note that the 21-22 figures do include cost of redundancy and early retirement linked to transformation. So when you strip that out, actually year on year, we see a 6% decrease in our operating staff costs across the 2 years, which kind of further adds to the positive note of our trading performance at the top level. This drop in staff costs was actually driven by the freeze in recruitment during the HR process of transformation. It was partly mitigated by contingent labour and partly by sourcing resource in other ways, not through staff costs. In terms of our total operating costs, they increased by 14.8 million year on year. 6.3% of this was the cost of external consultancy for transformation. The other significant one-off fee was a 2.3 million write-off of aged debt, particularly overseas debt that went back over several years. We also had 2.4 million of increased contracted out services, which was in part the change agenda, but also some of that support where we were lower on our resources. So overall, from an income and expenditure perspective, we realised a net deficit of 9 million versus break even last year. But if you strip out the transformation and one-off costs, then it's a much better picture. In terms of cash, we saw total cash outflow of 28.5 million versus 9.7 last year. This was largely driven by our focus on appropriately utilising reserves in our final year as a trading fund, with both the support of our operating cash flow and an increase in our capital investment in the year as we move into our new status. Linked to that, as a trading fund, the agency is required by Treasury to achieve a return averaged over 5 years of at least 3.5% in the form of an operating surplus on ordinary activities before interest and dividends. This is expressed as a percentage of capital employed. Over the 5-year period prior to the closure of the trading fund, we actually achieved an average return of 3.78. So we met our obligations as we close out these numbers. So that's just a little bit more colour. As the paper says, the board are asked to consider the performance of the year, in particular the path towards financial sustainability going forward, and also to take note of the return for 21-22. Thank you, Stephen.
Great. Well, thank you, Jo. It might just be helpful just to, again, for members of the public that might be watching, explain what happens from the 1st of April. So the difference between a trading fund up to the 31st of March and our new relationship with the Department of Health from the 1st of April onwards. Can you just sort of say a few words around that?
Of course, yeah. So from the 30th, I think it was October 2019, it was decided that our trading fund status would be lost from the end of March 2022, which means that for us, effectively the biggest change is that we lose the ability to control our own reserves and are formally folded into the DH accounting. So that's really one of the biggest implications. I think will come later in the discussion when with Carly talks around the framework agreement. There are some slight changes in there as well. But most significant in terms of our freedom to operate, if you like, is that we no longer have a cushion of reserves that we can access without permission from DH.
And therefore that means practically we've got to live within our financial budget each year.
Yes,
so
absolutely.
That is a significant change to the way that we operate. And therefore the question in the board paper around any impact on our future financial sustainability relates on our ability to manage our budgets within year and not have a reserve to be able to fall back on. I think that's a helpful explanation, Joe. So thank you for that.
Thank you.
So colleagues, can I just ask if there are any specific questions around the accounts as they currently stand? They are draft, as Joe said, unlikely to change significantly, but they may. Graham.
It's just a clarification from ignorance, really, but in terms of the change in trading status and the reserve that was there before, is that I can't see that factored here. Is that just finished? And what was the surplus that was left?
Yeah, so we had so within the, I will tell you the exact number. So our reserves, our balance of our reserves actually it's not formally swept by Treasury, but effectively we can't access them anymore. So we now have to, as Stephen said, we now have to access within DH, and I'm sure Catherine can help with this point as well. So we have to, whatever budget we now have set by the Department of Health for next year, that's the budget that we have to operate to. We don't have the flexibility to say we've got money in the bank, we can take it ourselves. But Treasury don't physically. Sorry,
just to answer Graham's question around what was left over. So it hasn't actually physically gone to the Treasury, but we can't talk about it. I assume that's the £51 million worth of cash and cash equivalents.
Yes. Yeah, it does get slightly adjusted for things such as our CPRD reserves, which we've been agreed that we can hold on to, some ARIS funds that we agreed to hold on to, but the balancing number we can't access.
So that sounds like the black art of accounting, Graham. So I think 51 million is the simple answer to your question, and
yes,
there'll be loads of technicalities around the reason why it won't be exactly 51 million. That's the way I interpret it.
Thank you, Stephen.
Michael's smiling, so it must have been pretty close. Okay.
Stephen,
any other? Michael.
Yeah, I'm sorry not to interrupt you. I think to give assurance to the board, when I looked at these accounts, there were no fundamental surprises. If you think that we have been kept informed, I think it's every quarter, and maybe more frequent, of the financial performance of the agency, there is nothing there that comes as a surprise. In relation to Graham's point, if you recall, as a board, we put a lot of emphasis in terms of value for money, making sure that we made the best use of those reserves, so that we didn't have to surrender them, that they were used to invest in activities of the MHRA that benefited the public. I think the agency did a reasonably good job. That was incredibly difficult. And 51 million sounds a lot that we've potentially lost, but the high proportion of that is the CPRD money that is still available to us. I know we have to go through some convoluted way of spending it, but it is still available to the MHRA. The key strategic point I take from it, Stephen, and it relates to a discussion that we had earlier, if you look at the segmented reporting, and by that I mean the looking at the three parts of the agency that are now part of the whole as such, we are recovering our costs. So what it does emphasise the importance of revisiting our fee structure and increasing our fees. We either increase our fees or we become more efficient and productive. It's as simple as that, and that's the fundamental challenge that I think as a board and an executive that we face going forward.
You see, I think particularly I took a lot of comfort, Michael, from the income line. And the fact that actually there was a 4 million growth in our income, which is effectively applications coming in. So the volume of activity from industry has remained strong, I think it's fair to say. And I think that's really positive, bear in mind we come out of Europe. Now we've got to continue to react and respond to that and actually provide the service our industry colleagues need. However, we need a sort of a strong base of income by which to then sort of manage the organisation. And then it's about managing the costs. I'm with you. I think having gone through these accounts in detail, my view is that there weren't any surprises there, and actually we've made conscious decisions to invest in various elements of the transformation. So I also felt quite assured by that. But June, obviously you're the accounting officer when it comes to having to sign this off. Any further thoughts from yourself on the draft accounts?
I think Joe's summarised it very well. clearly we need these further assurances before the accounts can be signed off, and we'll learn from them. But overall, coming to year end, I think we can be satisfied, given all the challenges of this year, that this represents a pretty good picture.
Okay. Right, unless there are any other questions, then I suggest that we note the financial results for assurance. They're still subject to audit, and actually I'll come back to the point on Michael in a moment. But I think we can note them as they've been presented to us, again, with thanks to the finance team for putting them together, and obviously every cost centre manager across the agency in actually managing what's been a pretty challenging year, I think is fair to say. Why don't we just complete the third item in terms of the next part of the report is then just around how the performance and governance of the MHRA will be reflected in the annual report, and then I'll come back to Michael's delegation. So, Carly, page number 41, how will the performance and governance of the MHRA be reflected in the annual report? Any introductory comments from yourself?
Thank you, Stephen. Not much at all to add to the paper. I think the kind of key point to note is that the mandatory requirements that we need to comply with for our annual reports and accounts are much more stringent around the areas that Joe has just covered, and around some of the governance areas. Notwithstanding, we've really endeavoured to take the opportunity to set out the agency's performance over this really quite challenging year, and tell the story about how we have delivered against the delivery plan, so that we have that virtuous circle of information for the public and for Parliament, as well as making sure that we are balanced in addressing, as Michael's referenced, some of the things that have gone really well and some of the things that could have gone better. So I think that's really the key point. Also, I'm sure the board will want to hear that we will do a lessons learned process after this. It's the first time we've handled the report in this way, and lots of close working with finance and with comms. So we'll be looking to build on this year's experience through lessons learned and further improvements.
Great. Okay. So I think there'll be a number of key sections in the annual report. There'll clearly be the performance report as Carly describes it. There'll be obviously the governance review in particular, and then there'll be the financial accounts once the audit has been completed. So I think it is a very prescribed format. That is the reality, and what I've heard from Carly is that we're meeting the requirements. But can I just check from anybody if there are any questions around either the process or any of the draft content that's been circulated outside of the meeting? I would take silence as a great achievement, Carly, on that basis. So I think that's it's been a huge team effort. A year-end process in any organisation is a really big event, and it's no less important in a public sector organisation either. So thank you for that. Okay, so I think we can note your report and the process for the annual report. So what we need then are really the financial accounts to be formalised and finalised by the auditors. Michael made a proposal that the board should delegate Michael as the chair of the Audit and Risk Assurance Committee to approve the accounts on behalf of the board, unless of course there are any material changes to what's been presented today by Joe and the team. And if there are any material changes, then I suggest that we'll have to have an extraordinary board meeting to discuss and decide what action to take. So can I just check if the board is content with Michael's proposal that we give him and delegate the authority to him on our behalf to approve the accounts? Okay. Again, I'll take silence as consent. So Michael, I think you're duly delegated.
Thank you.
I think in terms of the step, once, I guess the stepwise process is, obviously Joe will work with the external auditors and come up with a sort of final conclusion. Michael, you will then review that. Formally, you'll then make a recommendation to June as the Chief Executive and Accounting Officer to actually physically put the signature on the accounts, so that then the accounts and the annual report can be laid in Parliament before Parliament rises in mid-July. So that is, as I understand it, the process. Is everybody content with that? Carly, you're looking very serious. Did I accurately reflect the process?
Yes, thank you.
Yeah.
And Michael, you're content to take that responsibility?
Yeah, and I obviously will put a note to board colleagues when that process has gone through.
Okay, Natalie, can you just record that delegated authority, please, in the minutes for the formal record? That would be okay. Thank you very much for that. So we're not finished with governance, because actually that was latter. We now need to start thinking about looking forward and the future. And there's a really important document called the Framework Agreement between all linked bodies and their respective department, but in our case between the MHRA and the Department of Health and Social Care. So Carly, back to you again, I'm afraid, but actually, sorry, I've missed out June's Chief Executive's report, but so why don't we stick with the original plan? So let's go back to page 44 and talk about the current activities, June, as you see them, and then we'll come back to the framework agreement in due.
Happy to do that, Chair. Obviously happy to go with the flow and do this at the end, but if you want a bit of a break for Carly there, who's doing all the hard work, happy to talk about some of the current activities. And again, as ever, I say what a wealth of different initiatives and activities the agency's undertaking, and all thanks to the huge efforts and commitment of our very motivated staff. It's good to acknowledge that this month, June, 1st of June, sees the designated date for operational activities now in our new structure. Clearly, some of the teams have come into being from the 10th of January onwards, and now that 90% or so of staff are in new roles, that we can say we are actually in business in our new structure, and it's a great feeling, and we'll be launching our new One Agency Live in a week's time. So here we are in science, research and innovation, healthcare access, safety and surveillance, all underpinned by those really important corporate and other services, so that we can fully deliver for patients and the public. The report this month does record some really interesting areas in science, research and innovation. The focus up to now, as you know, has been very much on access and safety, but work is progressing well with our yellow card biobank. CPRD Sprint's got a couple of actual studies underway, and there's work on polio eradication that's progressing really well and is being showcased by international organisations to show what the agency's capability is, which is fantastic. And CEPI has continued to work, and not only that, extend the contracts for MHRA. So really important role of science, research and innovation coming from the agency. But our focus on access is always a key deliverable. The fact that we authorised a COVID-19 vaccine on the basis of immunobridging data means that lots of inquiries and requests for scientific advice have been flowing in, and colleagues will be well aware of the current focus on the rising number of monkeypox cases. So access to a suitable vaccine and an antiviral and the support for companies who can deliver these has been a really key role of our healthcare quality access team. And we note, in terms of working internationally, that this month saw the first medicines, one for serious eye diseases, faricimab, coming through the consortium Australia, Canada, Singapore and Switzerland. So we are really working as full members of that consortium. HRT access has been quite a big concern out there in many women's lives, and therefore we've been supporting companies with educational workshops, companies who may need to think more about how they maintain supply, also those who dispense this important category of medicine. Patient safety will always be our number one, and it's important that the Commission on Human Medicines, having started having patients participate with the recent isotretinoin safety review, now have had 2 sessions with patients on valproate, and it really has been illuminating for their deliberations. It's important too to show that we hold companies to account, or the processes of enforcement sometimes are lengthy, but do deliver, as you can see from the prosecution of a company that produced total parenteral nutrition, which was contaminated. And in terms of responding rapidly, in contrast, the insulin delivery pump that was leaky and the important advice that patients should be switched, that was really an important devices safety initiative. And it kind of gives the character to the devices legislation, where board has agreed we want patient safety when we revise the legislation always to be the priority. So a lot of work involved here, a huge spread of different capabilities, expertise, but all our delivery has been due to the staff involved and their commitment. So I'll stop there, Stephen. I'm very happy to have further discussion as needed.
Great. Well, thank you, June. I continue to be impressed by the sheer breadth of responsibilities that the MHRA has, and I think this report really captures that very, very well indeed. So thank you to you and all colleagues who've been involved in actually delivering each of those achievements. Junaid, do you want to kick us off, please?
Yeah, it was more of a comment, Stephen. I think you stole my thunder, but I was just also going to say the same thing, to say I think it's tremendous that the work that the executive team and the wider team are doing, and it's great to see recruitment now back up as well. So, and I think, June, in your words, that we're back in business. I'd also like to just comment that it's great to see the MHRA performing on that global stage. And the more we can do in that regard and harmonize consistency around what we do in conjunction with other global regulators, the better we would be. And I think the more public benefit that we can derive from that too for the patients and public that we serve. So thank you for all of that. And I'd like to see some more happening on that global stage moving forward as well.
Stephen, if I can quickly jump in, I should have highlighted membership of ICH as well as IMDRF. That's the International Conference on Harmonisation, as well as the International Medical Device Regulators Forum. There is so much we can do, as Junaid has highlighted, to enhance collaboration through harmonisation of our approaches. And we're seeing this as a huge opportunity now.
And that's got to be for the benefit of patients, and it's also got to be the benefit of industry in terms of having more consistent and aligned regulations. Paul, can I bring you in, please?
Yeah, just a comment. I think the Sprint program is fantastic. So being able to proactively reach out systematically to patients who meet trial criteria. So it's just sort of rephrasing, sort of rather than high quality patients, it's patients who meet the trial criteria, and in a broad way, so not just patients who live close to the trial site.
Yeah, I think that's so important, isn't it? Because what we need are clinical trials that have got representative populations within them, and so that becomes a really vital part. And when I think in the future we come back to clinical trial regulation, I'm sure we'll pick that up. But it's a really practical example of how one of our services can actually really help to address that. But June, I'm sure you'd endorse that.
Absolutely, and the fact that there's work going on to ensure that CPRD is really as representative as it can be. It also takes that concept into reality of taking trials to patients, because that outreach where someone is contacted and informed if they wish to take part in a trial, they meet all the entry criteria, is bound to start taking time out of that recruitment process, which will enable everyone to benefit from really good results sooner.
Right, thank you, Paul. Mercy, can I bring you?
Yeah, I've got two questions and one comment, and the first one actually is on Sprint. It's such a good scheme. Is too good enough? I mean, are we setting a target to get more of these, kind of using Sprint, because it is such a good scheme? Shall I stop at that and then come back to my
Yeah, I think let's pick them up, because I suspect Alison might be wanting to come in actually talking about CPRD. I see your hand's going up, Alison. Do you want to handle that?
Yes, thank you. Yes, Mercy, this is a new program that's just been launched relatively recently, and we're learning from it as we go through. We do have more targets for next year. Of course, that will be helped new infrastructure, new platform that's going to be launched to enable, we have the infrastructure to support new trials. So that's obviously a critical thing in terms of service delivery. And that will be that will shortly be launched. I would just actually was going to come back on the previous comment, because one of the really excellent things about Sprint is also the interaction with GPs, because in a couple of the trials, as we've learned, GPs will come back to us and say, well, we couldn't actually deliver those patients with those criteria. And if you actually change some of the criteria, then it would enable us to recruit more patients. So that's been a really useful learning process. But certainly it's very exciting new initiative from CPRD, and one that we're really keen to grow further in the future.
Yeah, and I think as an acronyms go, actually speedy patient recruitment into trials, which is what Sprint means, actually does on the tin. So I like that a lot, actually. So thank you. Mercy, you had a second question, I think.
I did. My second question is back to faricimab. In my previous life, I was tasked with eliminating avoidable blindness for the UK. So I'm very excited to see international cooperation kind of working in this way. Just my question really is having access for patients in the NHS. We've obviously approved it through this through the Access Consortium, but when will patients be able to get a hold of it? I mean, I think this is about understanding the larger system.
Yeah, obviously that's outside of our control, Mercy, as you well know.
Yeah.
But do you have any insight on that? You're on mute, June, I think.
The date for introduction of faricimab I don't have in front of me, but I know we can find that out. Yes, the concept that we should align regulatory health technology assessment and NHS pathway or guidance is absolutely central to the thinking now. And so while I can't give it to you for faricimab, I think that's a principle that we're looking at, and particularly with NICE, as to how we can get those decisions very much aligned.
Thank you, June. So the last is just my comment on the new oral polio vaccine, and I looked up those really useful information that we made a link through, and just it's quite amazing, and it's great that we can be on the cutting edge of this. So really congratulations to the team on doing that.
Well, Stephen, Mark's team might want to say something about it. It is really important research, because as I understand it, it's able to be more resistant to the variants that can be a problem in this area. Although it's been used to quite a high extent around the world, I don't believe anyone has authorised it yet. So maybe that's something Laura's team are thinking about as well. But it would be nice to offer Mark the chance to speak about this, because it really is important.
Yeah, I think we've got a few moments. So yeah, please educate us on the polio work you've been doing.
Okay, this represents a significant investment by NIBS and also its partners, the Gates Foundation, and of course it's part of the WHO expert lab for basically polio eradication. There are 3 strains of polio, and the team at NIBS developed 3 different vaccines. It happens that strain 2 has been one that's been deployed most in clinical trials in Africa, and it's a listed product by the WHO, which means it can be used in emergency situations, even though it's not approved. We're now moving to clinical trials with the other 2 strains as well. So it's very exciting. It's a huge combination. Its effect is that this vaccine cannot revert. So the Salk vaccine that was used for most of us as kids, there's always low chance of it reverting back to wild type, which means that polio begins to appear in the population. This is a great leap forward here. It can't revert, so it's a much safer vaccine.
Yeah, you see, I think again, just another example of how the MHRA is different from other regulators around the world, because we have NIBS, or National Institute of Biological Standards and Control, where we can actually do some basic, fundamental research. And this is a good example of the work that we're doing in that area, and the public health benefit it can have internationally, and not just in the UK. So I think actually as a regulator, we've got some really important, constituent parts that actually make us a very strong and capable organisation. So thank you, Mark, for that. Graham, you had a question.
Yeah, I mean, I think first of all, I make no apology for repeating how impressive the breadth of work that's gone on here is. So, I mean, it is very impressive. But two specific things I just wanted to ask about in relation to access and touching on what Mercy was saying. It's really great to see the first drug coming through ILAP and getting approval through Orbis. But the question is similar to the one that Mercy was asking about, when does it get to patients, which is really going to be our test. I know it's beyond the control of MHRA to some extent, but ILAP is trying to address that. Do we know how soon it might be available?
I don't personally, but I guess Glenn's team and together with Laura have been pulling all that together. If we can't tell you now, we'll certainly do so immediately after the meeting. But Stephen, Laura or Glenn may well have that at their fingertips.
Yeah, Laura, are you able to illuminate us? And then I might bring Catherine in a moment to explain the process of actually how our products go from us through NICE to the NHS, because I think it's really important that we're really clear about our role in that particular step. But Laura, is there any insight you can provide?
Yeah, no, I mean, it's obviously slightly different when we have ILAP, because the idea is to try and align those, but Faricimab came through the Access partnership, so that wasn't through that route. But actually the NHS, the NICE website is saying that it expects to publish guidance on that on the 29th of June, so that is imminent. But as you say, that's not within our control. But it would be helpful to sort of talk through the process.
Yeah. But Catherine, can I maybe just bring you in for a moment, just from a Department of Health perspective, because you've got a slightly wider view than we have, and obviously with your sponsorship of NICE as well as the MHRA. The uptake of new products, what are the steps that need to go through? So we've got a regulatory approval. What are the steps need to go through within the Department of Health before patients can access a product?
Well, there aren't any steps in the Department of Health, but what happens is NICE appraises all innovative new medicines for cost effectiveness, and they aim to do so within 90 days of licensing application, and they do that for all products where that time, those 90 days are in their control. So if there are delays outside their control, it will exceed 90 days, and they try and do it within less time than that if they can. It depends what they know in advance about and what certainty they have about the timing of the licensing decision, getting the information from companies and so on, enables them to schedule committee dates appropriately. Once it has been approved by NICE, the NHS then has 90 days to get it into routine availability. It's fairly quick, basically, if all things line up. But that is the legal maximums that are in place.
Yeah, that's helpful. You see, at one level, to both Mercy and to Graham, I think it's a completely unfair question because actually it's not our responsibility. On the other hand, I think we should have an awareness of it. So I think actually the point it brings is, if we're going to really join the system together and we're going to genuinely accelerate access to new safe products for patient benefit, I think how we have awareness of what the next steps of the program are, even though we might not be responsible for them, I think that might be helpful. So, I think that's actually not just a MHRA issue. I think it's the entire health system. So obviously we're only responsible for our component part, but I think an awareness of the next steps is probably something we do need to work at, is what I would suggest. But let's be really clear, that's not our responsibility, where our responsibility ends. And I think we just need to be really clear on that, because we can't take responsibility for the entire health system. In the UK, the Secretary of State might have a view on that.
No,
so, is all I would say.
And I think there's something about this, as you say, this is about multiple organisations all playing their part. So MHRA, NICE, the NHS, and the company as well. It's a concerted effort to get a product through all the stages and into patients.
Yeah, and before that, of course, there's Health Research Authority. There's the National Institute of Health Research. You've got Health Tissue Authority, so there's multiple agencies across the entire life cycle, and we are one small part. And I think we just need to be really clear about that. But how we get awareness of what the next steps are, I think, is an interesting question. And I think we should maybe come back to that. And, I think actually, Natalie, we should maybe just take an action in terms of how do we retain visibility post-authorization on NHS availability. I think that actually is maybe going to be a helpful thing to establish how we do that. Graham, do you have another question?
Yeah, I mean, I think they're both fair questions, but I agree with you. I mean, it's not within the remit of the agency to be held to account for it, but keeping an eye on that would be really helpful. The second question was really about the drug that we've mentioned, faricimab, and the fact that it's been approved by the Access Consortium. And it's really the broader question about working with different consortia, and in this case, what we can learn from it and how this worked differently from what would have been business as usual. And whether there are other ways that those learnings can be taken forward. I don't know if there's any insight we can have from that.
Okay. So I was thinking of the international sort of mutual recognition processes, so such as Orbis or Access.
Yeah, so the way this works with Access is that, I mean, in a business as usual process, there are several different parts of an assessment. So we look at the quality, we look at the non-clinical data, we look at the clinical data, and we look at the risk management plan for follow-up post-authorization. So those are the elements that we look at. So if that was something that was just a national application that MHRA was processing, then that would go, and considering that would go to different parts of my team to look at that, and to an extent Alison's teams as well. What happened in Access, and what happens when we do something with a consortium, is those different bits go to different members of the consortium. So we will take one part, the clinical data, for example, and say TGA will take the non-clinical data, and then all of that comes together. What is the same as a business as usual process is when you get to the end of that process and all the assessment has been done, there is still an MHRA decision, and all of the data still goes to our Commission on Human Medicines to consider all of the outputs of that, to consider whether the risk-benefit decision is favourable for authorisation. So that's where it comes back together at the end. I think in this case with this drug, I mean, it worked very well in terms of everybody doing their part and it all coming together. I think what it's taken longer than we would have wanted it to. So it's 10 months end to end, more than 10 months end to end. And that's not what we're aiming at with this one. So the lessons that we need to learn around that is what can we do within that process to expedite that a little bit more in future processes. But it's basically the same as business as usual, but it spreads across different, so it spreads the work, if you like, and brings in different agencies into that.
Okay, Graham, does that answer the question?
Yeah, no, I think that's helpful to understand. Thank you.
Yeah, great. Okay, Glenn, were you going to come in on the earlier point? You did have your hand up briefly.
Yeah, briefly, just to say that we've got a timeline of faricimab, not the timeline inside the Access Consortium, but we approved on the 16th, and draft guidance from NICE was 24th of May, and so their appeal process takes them to the end. So actually, it is quite joined up. I realise we're not responsible for it all, and we do the work up to the approvals in partnership with them, and then also with the NHS. So we are building those things that you talked about, that awareness of both upstream and downstream of our authorizations and how that sits in the system. So just wanted to give a positive response on that.
Yeah, I think that's helpful context, Glenn. Thank you for that. Junaid, you had another point.
Just a reflection really about how complicated the system actually is. And as we start thinking through our role that we play, but then our role around engagement with and involvement with the public, I almost think, Stephen, about the King's Fund video that they've just launched around integrated care systems and trying to explain that to the public. Should we collectively, under DHSC, have a collective responsibility to try and create clarity here around how different groups get involved across the pathway? And of course, I think when we talk about the NHS, we have to remember that the story doesn't stop there. We still have a responsibility around yellow cards, post-market surveillance, ensuring patient safety, but also, although it's not our entire responsibility, the NHS then can create access, but the community still has to encourage and demonstrate confidence in the prescribing community to feel safe in the prescribing of drug X, whatever it might be. And so the story doesn't end, and it's constantly reinforced about the safety story and the confidence story. And that may be, I don't think that is made transparent unless you live in the system. And it may be something that we need to take away as we start thinking through our role in patient public engagement and involvement, but also share that with NICE, with NHS England and others as we embark on this collective story for patient safety.
Yeah, I think it's an interesting reflection. You know, I think we could spend a lot of time trying to explain how we're wired, and people will just say, well, that makes no sense. But I think we do also need to be able to sort of give a level of public confidence actually of how the system does link together, so that actually safety, at every stage of that product development life cycle, and then into use, and then post-use, and how we're actually doing the safety and surveillance, linking to that all together. There probably is something we might need to think about how we do that. And we've talked previously around trying to explain some of our regulatory processes on our websites, for example. So I think there's maybe still something in that we'll need to come back to. But June, you've obviously sort of worked in this environment for a long time. You know, you understand how the system works, but in terms of trying to explain it to patients, have you got any perspective around the best way we could maybe do that?
I think listening, for example, to Laura just now, I'm sure it's possible to put things into very accessible and clear language, and particularly if there's good graphics. So it might be a project that we should take away and work on. What I'd suggest is that we really do need to start publishing our own public assessment reports. I don't believe we do at the moment. And that's often the way when actually an interested patient group or member of the public wants to really delve into the detail, can see how we made a decision. So that might be something as well on a specific product by product basis that will help people to feel actually they've got their heads around the few questions. Is it safe? Does it work? Anything I need to know to use it properly, or maximum benefit, minimum risk? We talked at some point today about patient leaflets weren't as accessible as they could be, and perhaps Patient Safety Engagement Committee might, with our support, have a look at some of these areas, because I'm sure the kind of questions that colleagues on the line get all the time from patients are the very, very basic ones. Does it work? Is it safe? Anything I need specially to look out for? We can do things in that way. And a BNF for patients, something like that.
Yeah.
British National Formulary.
Yeah. So I think actually it's your report always sparks conversation, actually, June, because I think it's the sheer breadth of things that created there. But there is still, I think I'm picking up a theme here around communications, not just in terms of how the system works to keep people safe, but that's a component of that. How we make decisions on individual products, and how actually, as an agency, we have awareness of availability in clinical use through the rest of the system. So there's definitely both external and internal communications, I think, requirements around there. And I think actually, the point you just made there about maybe the Patient Safety Engagement Committee taking another look at patient information leaflets. I think we'll need to think about scheduling that in Mercy. So I don't think that'll be a quick decision, but I think it's probably worth coming to in your schedule. So maybe we should actually just talk about the timing of that outside the meeting, but I think that might be quite helpful as well. So, okay, colleagues. So unless there are any other questions, I think that's helpful on the communications, actually. I appreciate that very much. So why don't we note the report for assurance and context? That was the purpose of the report. And thank you, and we'll move on to the next topic. So, Carly, I was a little premature earlier. I was so excited to talk about more governance. So now is the time we can talk about governance on page 52. And it is about the framework agreement. So without, I hope I didn't steal too much of your thunder earlier, but do you want to tell us about the framework agreement and why we need it?
Certainly. You never can have too much governance is obviously the maxim that I live by. So the framework document, I won't labour the points that are in the paper. It has been a substantial piece of work with Catherine's team in the department, and I think comes at a really good time to update and reflect all of the change that the agency has gone through. We've already touched on the trading fund change, and that is reflected in the new draft agreement. There's one or two minor final tweaks to go through on the paper, and then it will go through clearance in both sides of the sponsor relationship. But it is important to note that many of those kind of macro accountabilities, if you like, the role of the board, the role of the accounting officer, the role of ministers, remain the same as established accountability and governance principles. So we've really used this as an opportunity to bring everything right up to date, and then I think set a new basis for a new type of sponsorship relationship with the department, again reflecting the changes that the agency has gone through. And that sponsorship relationship is something that Catherine and I will be working on far more informally most of the time than the framework agreement envisages, but with the input of all of the colleagues. I think the other important thing to remember is that this really is a key kind of cornerstone document for the governance of the agency, and with this in place we can move forward through the work that we've identified, and that will certainly pick up some of the discussions we had earlier around schemes of delegation, clarity of accountabilities, enabling decision making at the right levels in the organisation, and ensuring confidence and control in doing all of those things. So just to wrap up, once we've gone through these final process points, it's cleared on both sides and then signed off by Treasury, the new framework agreement will be published on gov.uk.
Perfect. And just to be absolutely clear, this is framework agreements required across the public sector. This is not just MHRA specific. The details specific, but the principle is not.
That's correct, yes. So this incorporates a new update, a new template that has been developed by Treasury for executive agencies. But then, as you say, we fit the specific MHRA detail into that framework.
That's great, thank you. And Catherine, obviously you've been on the other side of the negotiating table, as it were, from the Department of Health. Any additional thoughts or comments you want to add?
Just so that, as Kylie says, this is a helpful process to go through every few years. It's just to remind both organisations about what our respective responsibilities are, how we should work together, the things that we all should take into account, like managing public money when doing our work. And then, as Kylie says, we then get on with it. And it's there if we need it. But actually, the important thing is the relationships and the communication. And that's what we all work on together informally. And Kylie and I will continue to reflect on and try and improve as we go.
Yeah, certainly observing the process, it feels like it's been a very collaborative process, Catherine. So thank you to you and your team, but also thank you to Carly and her team, because actually this is the way we're going to get a sensible agreement that we can actually establish the principles and then, as you say, get on with it. So I like that very much. Just before I bring Michael in, Sash, could you just promote Andy into the room and for the next item, please? That would be helpful. Michael, you had a question.
Yeah, just to an observation and a question. I think it's a really good document, so congratulations to everybody. It came up at ARAC yesterday. I particularly like, I think it's paragraph 6.2, it shows I've read it, which lists all the statutory functions of the MHRA. And I think I think it was internal audit made the point yesterday that periodically it's not a bad thing to actually look at those by the board and just to, are we confident that we're discharging each of those in the best way possible? I'm not saying we make heavy weather of it, but because the majority of our reporting gives us that assurance, but it is a very comprehensive schedule of what our responsibilities are. And I think periodically it would help to support June to be able to see that, that we are meeting those, or that something is not being missed. And my question really to the department is, shows I'm a bit old in the tooth here, do they still do quinennial reviews of executive agencies? It used to be every 4 or 3 years there would be a formal review of the executive agency. Does that still go on, or has that been abandoned as such?
No, they still happen. They shift between triennial, quadrennial, but yes, we do still hold regular reviews. MHRA is not included in the ones that are imminent because of the transformation programme. We wanted to give that time to bed in before we did another review. But when the next period of scheduling comes round, we'll consider that, the timing of MHRA's review, and we'll do that with you.
Okay, thank you very much. Thank you, very helpful.
Okay, that's great. June, any thoughts from your perspective? Obviously, you know, as the Chief Executive and Accounting Officer, you know, your role is included throughout this document.
Well, I'm
with a number of
really pleased to have this. As we've heard from colleagues, it's good to give it a once over and shake out any issues that have been troubling us, and make sure that our relationship is set fair for really good and effective working. Carly's nice paper kind of is the culmination of a lot of work, and I do think it was a healthy thing to have some debates about the corporate and business planning process, where policy properly sits, and so on. And I just think perhaps the board, obviously you're seeing the smooth surface, but underneath there was some really healthy rippling, and I'm just very glad that we're here today with what we have. Thank you.
Great. Okay. Colleagues, any final questions around the framework agreement? I said it's a fundamental document around reinforcing the roles and statutory responsibilities that the agency has on behalf of the Secretary of State and the government. No. Okay. So again, I think we can therefore note that paper again with thanks. So I think I really appreciate the work that's gone into that, both Carly and to Catherine and your respective team. So thank you very much for that. Sash, I don't know, I don't see that we've actually got Andy's online yet, but we do need to move on to the next item. So please promote him as soon as he's available. That would be great. So Alison, the next paper is something completely different, as they say. So it is around looking from patient safety, but this time from a criminal enforcement perspective. And there's a very interesting paper that's prepared around what are the key priorities in the MHRA enforcement strategy, and how does this help keep patients safe? So would you like to make some introductory comments, Alison?
I can make some introductory comments, but for the detail of the paper, we would need Andy on the line. So hopefully he'll be able to join soon. So the paper really sets out the key priorities in the MHRA enforcement strategy going forward as it's moved into my team in safety and surveillance. And the structure and the operating model of the criminal enforcement unit in the MHRA has undergone a really substantial refresh as part of our transformation process, refocusing its activities into prevent, into 4 different areas, bringing on stream much more intelligence gathering, more evidence generation, and baking in, as it says in the paper, more innovation and disruptive thinking. With the aim, of course, to bring about a step change reduction in the context of a sort of changing landscape in terms of criminal activity around medicrime. And of course, that includes both medicines and medical devices related offending. And the paper really, and I'm sure the board has read it, sets out the ambitions of the unit going forward over the next 3 years in terms of realising this sort of strategic shift in priorities.
Great. Well, thank you for that, Alison. I must admit, from a personal point of view, I think just looking at paragraph 3.15, there's some really significant achievements there. And again, I think the board should note its thanks, because actually the removal of 5.5 million doses of illegally supplied medicines, prison sentences handed down totaling 106 months, the denial of £370,000 worth of criminal profits, and the removal of more than 30,000 illegally trading web pages, I think is actually really, really significant. So I think we should record our thanks for those very impressive results. Now, I've just had a note to say that Andy Morling, who's our Deputy Director for Criminal Enforcement, is having trouble joining the meeting. So
Stephen, sorry,
I think we'll have to carry on anyway.
Stephen, sorry, I think he has joined, so I'm going to give him permission to talk now, but you won't be able to see him on screen because he's had to join via a landline.
Okay, right. Thank you. Andy, can you hear us? Hello, Andy. This is Stephen here. So, Andy Morling, welcome. You're the Deputy Director for Criminal Enforcement. You've joined just in time. Alison has done a initial introduction of the paper, and just about to go into questions. So, I think, Paul, you were going to ask a question.
Well, it was partly sort of in case Andy wasn't able to join, so I was going to dive in and ask Alison a question, but also to Andy. So if Andy wants to talk first, I will wait.
It's okay. We've read.
Okay, I will go ahead. So I mean, I think it's sort of really impressive. So quite different to what we normally talk about, but I think there are links to some of the other themes that we discuss elsewhere, in particular, sort of the linkages of data. And being able to take more of a public health approach to some of the drivers behind crime. And I sort of look at it's a bit of anecdote of my own, sort of what I see locally, a patient who turned to the internet to source benzodiazepines because they couldn't get an appointment with their GP. So GP access, particularly in the left behind areas, is a problem. Also, some of the success with opiate prescribing, then seeing a correlation with the price of illicit heroin going up when the deprescribing is effective. So if you sort of look across all of those different pockets of data, you can maybe sort of direct efforts more appropriately.
That's interesting. That's looking at intelligence, definitely from the clinical perspective there. Andy, do you want to respond to that in any way? Just in terms of the way that you approach identifying issues and where to target your activities?
Unfortunately, Andy's still experiencing some difficulty in accessing the meeting.
Fine. Okay. Well, I think we'll have to call that one done. So Alison, could you actually, maybe sort of provide any context from your perspective? I haven't got the detail, but just thinking around the way we approach identifying priorities for targeting.
Yes, it's incredibly complex, and I think that some of the points Paul makes there are. Oh, Andy, are you able to talk now? No, maybe not. It's incredible. I mean, we hear that 1 in 10 people are buying medicines online now, and so this is an incredibly important area and really fits with the sort of renewed focus of the Criminal Enforcement Unit to think about how we can better prevent crime. Andy, can you hear us?
Yes, I can hear you now. Can anybody hear me?
We can.
Yes, we can. Andy, at last. We've been talking for 5 minutes. I'm sorry we've had difficulties accessing the call. So, Alison, do you want to just finish your point?
Yes, I can finish the point and then I can pass over to Andy, because this is a key area around the new strategy of preventing crime rather than allowing crime to happen and then prosecuting offenders at the end of the process as such. And therefore intelligence gathering and data sources, as you mentioned, is a key part of that. And Andy has refocused the group to really have an intelligence unit within the Criminal Enforcement Unit to generate just the sort of evidence that you're talking about. But Andy, shall I pass over to you?
Thank you, Alison.
So Andy, just before you start, just to give you the context, we've talked through the paper, so we don't want to go back to that. But Paul's question is related to how do you identify potential threats? So I think it's the identification of potential risks for you to target your activities. So that's really the question, just so you're fully up to speed where we're at in the conversation.
Great, thank you very much, Stephen, and good afternoon, everybody, and apologies for my technical ineptitudes. So yes, a really good question and a really important question. I would say that in 30 years in the law enforcement profession in government, I've learned a few very basic truths, essential truths, and one of those is you can't solve a problem unless you understand the problem. So as Alison has alluded to, one of the key areas of focus for the Criminal Enforcement Unit moving forward is to understand the threat. Understanding the threat helps us to address the threat in appropriate fashion, but also to prioritize and to work out where we should put our resources. In an ideal world, we'd have infinite resources to tackle all criminal threats, but clearly that's unlikely ever to happen, and we have to focus on those threats that cause the most harm. Now, the question was how we do that. So as we build our body of understanding of the threat, we do that by collecting intelligence. We do that information from all sources, from human sources, from open sources, from closed sources within government and from partners. And we overlay that understanding onto a standard risk assessment model that's used across law enforcement, used to prioritize topics as diverse as terrorism and child sexual abuse. And we find it has utility in prioritizing in our work area too. So we go into that risk assessment process with what we hope is a single picture of the criminal threat or a contemporary picture of the threat. And we use this tried and tested tool to pull out our strategic priorities for the year. So it's academically validated, it does the job, and it replaces the vagaries of human preference with something a bit more defensible.
Yeah. Okay, that's very helpful. Thank you. Paul, did you want to come back on that? You look like you want to say something else.
Yeah, I mean, it's really interesting. I mean, I had no idea that the figure is so high. Alison mentioned of 1 in 10 patients buying drugs illicitly. I wonder whether there's a sort of a loop to then be completed in informing clinicians of the demographics of patients, their conditions, areas and drugs that this is particularly applying to, because this might help how we practice medicine and address shortfalls.
I think that's true. An important part of the enforcement effort, particularly with the remodeled criminal enforcement unit, is to tackle the demand as much as we tackle the supply. Traditionally, we've focused on arresting the bad people and tackling the supply end of the equation, but we cannot ignore the demand because it's a demand-led crime. So yes, we're looking to engage with partners across the medicines ecosystem to help do what we can to reduce that demand, either by putting out messaging around the risks associated with buying medicines from illegally trading websites, but also to the healthcare profession to help them understand the drivers that might lead people to becoming customers in the future. Because quite often, I think a lot of the people that are buying from these illegally trading websites don't know that they're buying from a criminal enterprise. They don't know that they're potentially funding global crime and organized criminal groups by doing this. So I think education is an important part of the new capabilities we're building into our unit.
Thank you.
Yeah, that's an interesting point, is that if patients don't always know that they're buying from an illegal website or whatever it happens to be, then that actually is something that we've got to think about quite carefully. Claire, you wanted to come in.
And I'm not sure if this is a helpful comment, because it's partly because for my curiosity as well, but you talked about partnering with other organisations in the health sort of ecosystem. Do you do any partnerships with other sectors? So National Crime Agency and HMRC, for example, I know they have their own remits, but they have some overlap with the kind of things that we're talking about here. So that's my curious question.
Absolutely, another really good question, Claire. So yes, we do. Quite frankly, I'll work with anyone who cares to work with me in tackling this problem, and it's really important that we expand beyond the usual suspects in partnerships. And criminals don't distinguish either. Criminals, quite often we find that the criminals that are involved in our crime, in medicrime, are also involved in other things. They just look to make a quick buck. So you'll find they're involved in benefit fraud as well. So therefore there's scope to cross over with DWP. You'll find they're involved in VAT fraud also. So there's customs connections as well. So absolutely we do. We're tapped in to the NCA in particular, that operates obviously in the organised crime space, because we are finding that increasingly organised criminals are attracted to our area of business. The profits are huge. The chances of detection, as far as they're concerned, are fairly small, and we have to try and reverse that. And part of the effort is how can we change that business model? How can we change their view that this is somehow a risk-free, profit-high enterprise? But yes, Claire, forgive me for my sort of lengthy answer, but yes, we do, and we're looking to establish new relationships to try and tackle the crime in any way. Many of you remember that Al Capone was ultimately apprehended on tax evasion charges, and I'm happy to use those techniques to do whatever we can to address metacrime.
I think you and I should have an offline conversation, because obviously Alison and I work closely together, so on things like the data strategy and so on, so ensuring we're meeting the data needs of everyone across the agency and beyond where appropriate, but just from a digital and technology perspective as well, because I do work in partnership with some of the organisations that we've talked about, so let's do that offline if you're happy to.
Yes, I'd like that, Claire, very much.
Okay, I think that's helpful, Claire. You know, I think it's a moving target, Andy, isn't it? That's the reality. So you've got to keep the approaches to keep ahead of the game, I think. So, Laura, you had a question.
Yes, I did. Andy, I mean, it's a great paper, and I completely understand that the activities that you undertake and your priorities have to be intelligence-led. I guess my question is about whether there is a balance between that, to strike between intelligence-led coverage and coverage across the whole spectrum of all of our business, because coverage has a deterrence effect itself, if you see what I mean. It's almost like if you have a priority in one area, does that actually make the risk in another area more vulnerable? And I think in that context, I was delighted to see the plans to do a full intelligence assessment on the devices threat, because I think that's really, really important, and I think that's going to be a growing area of our business as we move forward, not the illegality around it, but devices itself. So interesting. Your thoughts on that, Andy?
Yes, you're quite right, Laura. What I will stress is that our priority threats are exactly that. They are our priority threats. We keep all our threats on the list, if you like. So this is not about excluding other areas of criminal threats, but prioritising those that cause the most harm to the public, which I think is the intellectually defensible way of doing it. But that doesn't mean to say we don't do things about those things that feel lower down the threat. We just prioritise the others. And the response isn't always the same either. I think it's about a blended response. So we may bring out our big guns, if you like, to deal with the threats that intelligence tells us are the most harmful to patients. But we may apply some other tools. We may tier our response to those lesser harmful crimes to ensure we do have the coverage. So it really isn't about not having coverage, because I think you're absolutely right. We do need to have coverage across the agency's statutory responsibilities, because, well, the law requires us to, beside anything else. But the response might be different for different levels of crime. I think it's right and proper that we invest our resources primarily in those things that intelligence tells us harm people the most.
Yeah, proportionate and targeted. I think they're two good words there, Andy. That makes sense. Hader, can bring you in, please.
Thank you, Stephen, and thank you, Andy. This was a really, really interesting paper, and I've been looking forward to it personally. So, and it didn't disappoint. I'm just interested in how much of your work is proactive and how much of it is reactive, in the way that, my background is IT, and I noted that 30,000 illegal trading web pages. How many of those, for example, did we find ourselves? And how many were flagged up by other organizations? And really where I'm going with that is, how much do we work with our other organizations to kind of give them keywords that they can search for on their systems to help prevent some of these web pages or flag them up to you? What's that interaction like? And I guess this question really builds on Claire's question about working with other law enforcement agencies, but my question is more about how much do we work with other kind of tech giants in the area and help them highlight these to us? Does that make sense?
Absolutely, and I think you've hit on a key point of the paper. We are strengthening our online capabilities, full stop, because I think we recognise we've fallen behind a little bit. We haven't really developed in keeping with the way that the online trade has developed. So the first point I'd make is we are investing more in that. The 30,000 websites you mentioned, as it happened in that particular example, and it's probably a good example, they were all identified by us, but us working in partnership with both a private sector entity and another government agency with a very heavy footprint in this space. So this was a really good, it was a proof of concept. In fact, we were looking to see whether we could industrialize the identification of these websites and also industrialize the taking down of these websites. And so that is the model moving forward. We won't be able to do this on our own. That's another one of the essential truths I've learned in my career. There's no way you can do this alone. So we are looking to continue that partnership, strengthen that partnership, and put in place technical mechanisms, technical solutions that will place a bit of a ring of steel around the UK in terms of access to these websites. We think that's a far better way of doing it than just playing whack-a-mole and knocking down a website one day only for it to reappear the following day with a new name. It serves a purpose, taking down these websites, because we're disrupting the business model, making it difficult for people, but it isn't the long-term solution. The long-term solution is to work with the tech industry, with the internet industry, both in terms of its infrastructure and service providers in the UK, to try and find a way of building a ring of steel so these sites aren't accessible to UK consumers. That to me is the money shot, if you like. That's the point at which we'll have achieved something quite significant in the online space, when we can prevent people getting access to them in the first place. It doesn't matter that they're still up in Moldova or where it happens to be. The fact is they're not accessible to people in the UK, and that's our ambition. We clearly can't do that on our own. So yes, we are looking to strengthen those partnerships with industry, with the tech industry, strengthen the partnerships with the internet service providers particularly, and other government agencies that are perhaps bigger hitters in the space than we are.
Thank you, Andy. Great work.
Thank you.
Yeah, it's really complex, isn't it? But the ambition, I think, is great. Mandy, I think we've got the last question from you.
Okay, thanks, Andy. Yeah, again, some great work. My question is really around the supply chain. So we're looking at the websites, which is the sort of entry point, but what opportunities are there for disrupting the supply chain, either of counterfeit drugs or diversion from the legal supply chain, and what are pharmaceutical companies doing to help ensure that isn't, because there must be something that these agents are actually supplying to people via their websites. How are we disrupting that end as well?
Okay, yes, that's quite right. I mean, they've got to get their drugs from somewhere, haven't they? So we tend to find, or our intelligence tells us, that the majority of the medicines that are sold by these illegally trading websites are sourced not from the from the UK. They're sourced from South Asia primarily, and the supply from South Asia into these groups is not in itself unlawful. So there's a ready supply of generic medicines. These are unlicensed medicines, obviously, in the UK. So there is a supply chain that exists between South Asia and these organised crime groups that exist around Middle and Eastern Europe and beyond. And the way it's a very difficult area to tackle, because this is a legitimate trade for India in particular, and we have to be very careful how we manage that relationship. But we do have a very strong relationship with the Indian Customs Authority in particular, and we're currently finalising an MOU with that body, where we will exchange intelligence, where the Indian Customs Authorities will share intelligence with us on suspect shipments that we can interdict, to try and reduce that supply. But I won't lie to you, it's a challenge, because this is something that we have no jurisdiction over. All we can do is use soft power, if you like, to try and influence that activity. But unfortunately, it's difficult to stem the supply entirely into the illicit market. We have more success. I think the solution, I guess that's the third of my accepted essential truths, is that we have to do several things at the same time. So influence activity in South Asia in particular, to try and stem the supply into the black markets, and also to work closely with our border colleagues here, which we do. I think I mentioned that in the paper, the really good relationship we have with Border Force, to try and interdict at the point of entry into the UK. So the combination of pressure, or soft pressure, if you like, at the supply end, putting that physical ring of steel around the UK at the receipt end or the importation end, and working with the online supply in the middle to try and defeat that. That's where the solution lies, in my view. Multiple different approaches simultaneously. But the reality is that is a challenge for us. That particular supply route is a challenge for us.
Yeah. Okay. Well,
Okay.
thank you, Andy.
It's really interesting. Thanks, Andy.
So I really appreciate that, Andy. June, I wanted to give you the final word on this, because obviously it is ultimately about helping and supporting patient safety. Just wondered, from your perspective, is there any final comments on this session?
Well, there's clearly a really good and strategically well-argued focus on where there may be very significant harms, the supply chain being compromised, counterfeit and so forth. But I also wonder if we referred at the beginning to online sales, 1 in 10 people buying, as you said, benzodiazepines, opioids, etc. Could we be looking at that? I gather the legislation going through Parliament on online harms isn't going to include medicines. So there might be something we ought to reflect on. The other area for compliance is using transparency more. I think the US FDA is much more transparent about posting when it has concerns about compliance. And we tend to keep things under wraps for a long time so as not to compromise any legal action that might be needed. So I wondered what your thoughts were, Andy, about those two things. Should we look more intensively at online access, the online pharmacies and so forth that spring up, and the purchasing habits that are being embedded now in the public? You can't get an appointment, so just get your benzos online. And secondly, using transparency.
Yes, Jude. Really good questions. So, yes, I think I hope the one thing that comes through in the paper, it's the recognition that we have lost a bit of ground in relation to the online threat, not just because perhaps we haven't built those capabilities ourselves previously, but because the world has moved on. Over the last 2 years, people have become ever more accustomed to availing themselves of the online space for all purchases. And I think there's sometimes a lack of recognition that medicines are different. You know, they're not like other consumer products. So I think there's been an acceleration of the online threat, both the legal trade online and, of course, the illicit trade online. And sometimes it's hard to distinguish between the two. So please be reassured, we are absolutely focusing on online. It is ubiquitous. You know, 99%, I would say, of our criminal threat is online based, which means 99% of it's also offshore. And I think that brings its own challenges to us. So yes, June, absolutely, that's the way forward. Forgive me, I forgot what your second question was, June.
I'm just wondering if we should change our regulatory approach, particularly now that compliance is in Laura's area and enforcement with Alison, whether we should be doing a bit more using transparency, as the FDA does?
Yes, I think there's space for that. There's a tendency within my profession to not talk about what we do, and that's not where I come from. I have to say, I'm a great believer that there is a huge deterrent impact, or a subtle deterrent impact, by publicising our successes, publicising the work we do. And I think we do need to have a greater profile publicly about the work that the agency does in this space, both in terms of compliance and at the sort of sharp end of criminal enforcement. So I think it serves two purposes. One, I think it's the right thing to do for transparency. The public pay my wages, I'm acutely aware of that. So I want the public to be able to see how well or what we're doing in this space. But also, it's about that deterrent effect. To some extent, it may be smoke and mirrors, but I think anything that can change that risk-reward equation in the minds of those people that are seriously non-compliant and criminal in their behaviour, anything that can contribute to that, and I think good, targeted, sensitive communications is key to that. So I want to be out there a lot more. I want people to know what we do and that we're protecting the public in that way.
Again, it's another communication issue, I think, June, isn't it? It's another example. Maybe we can be more proactive in our comms. I'm sorry, Claire, we're going to have to move on, I'm afraid.
I'll just type a note in, but it's only a quick comment. I'll type it in the comments.
Thank you. because what I don't want to do is to cut off the opportunity for public questions. But before we do that, I'd just like to, we're being asked as a board to endorse the 3-year strategic mission of the Criminal Enforcement Unit. Can I just ask if everyone is content to endorse the approach? Yeah, I'm seeing nods and thumbs up, so that's great. So Andy and to Alison, thank you very much for your time. Sorry about, you've both had technical difficulties today, but I think we got there in the end. So appreciate your time. Please thank your team for all the good work, and the board will endorse the paper that you've proposed. So that's great. So we can note that in the minutes, please, Natalie. Thank you very much. And that moves us on to the last item on the agenda, which is one of the reasons I was keen to that we don't cut that short, which is what questions do members of the public have about the items on the board agenda? Carly, I've seen in the chat that there's been a sort of a number of questions being asked. So is it possible for you just to sort of take us through one at a time, and we'll see if we can answer them?
I will certainly do my best. We had a question about the illicit sale of medicines and whether manufacturers were ever traced, which I think actually was picked up in Mandy's question, and Andy has addressed that one. So I will take you instead right back to the beginning of the meeting, if you don't mind, Stephen. We had a question about conflicts of interest. And that question was, can panelists be independent regulators if they work on boards for NHS trusts, etc.?
Well, that's an interesting question. So I think actually, as an independent non-executive director, and I count myself in that because I actually am the chair of the MHRA and I'm also the chair of an NHS integrated care board. I think for me, the way I've thought about it is the roles are very different. Our role, and particularly the non-executive directors on this board, are not responsible for the independent regulatory decisions. That's really very clear. But our role is actually trying to bring other experiences from outside of the MHRA to help inform the strategies that we need to deliver. So at the end of the day, decisions are not made through, so for me, actually, I think the point is that we're not making regulatory decisions as a board, we're providing strategic direction. I don't think we can do that unless we've got an understanding of other parts of the system. So I think actually we've made an active choice to bring non-executive directors onto this board who've got a range of different experiences. And I think that's personally very healthy. And because it doesn't then interfere with the regulatory decision making, I actually think that also keeps a nice clear blue water. So that's my perspective. But Mercy, I know you're also in the same position. You're on an NHS board too. Anything you want to add to that?
And I'm very clear that I don't work for the NHS, even though I sit on an NHS board. In fact, I'm there to make sure the NHS is accountable to the public. And that's how I sit on this board as well. So our roles are very different. So even though we're on the, I'm on an NHS board, and I have been in the past with NICE, it's there to make sure that that board is accountable to the public. So I'm kind of there for you, really. Yeah.
Claire, is that a legacy hand, or have you got any interesting conflicts of interest?
It's legacy.
Thank you, that's great. Okay, Carly, another question?
Yes, thank you, Stephen. Moving to the accounts paper that Joe presented, we've had a question about the high level of non-staff costs, and associated to that, a question is whether some of the staff that have left the agency could have been retrained into roles within that non-staff cost.
Okay, maybe June, can I ask you to pick that one up, and then we can maybe talk about the non-pay costs through Joe. But in terms of the retention of people within the agency.
Yes, we've really, as an executive team, made huge efforts supported by our HR team to enable staff to be redeployed, acquire new skills, develop their careers as a result of the introduction of the new structure. And I'm very clear that those that in the end took advantage of voluntary redundancy were people who, for whatever reason, weren't able to take advantage of those offers. It's one of the reasons it's taken us longer than we expected, and that was the intensive work to support people in their career pathways. So I hope colleagues can be clear on that point, that the retraining and so forth was certainly part of the offer. And where it wasn't accepted, there were very good reasons that it was not suitable alternative employment.
I think the key point there is, I think the key part there, June, is the word voluntary. There were a large proportion of the people who left voluntarily through either voluntary exit or voluntary redundancy. So in that sense, the individuals had the choice as well. So that's a component of that. Joe, I think there was a question then in terms of the relatively high proportion of non-pay costs. Is there anything you want to comment around that?
Yeah, I think I would just say, I think as we noted during the section, they are inflated this year because we've got some one-offs with both transformation and the debt write-off. That said, the non-staff costs do form part of our transformation activity in terms of cost saving. So we've got a number of activities currently ongoing to reduce those over time, notably the accommodation change at 10SC, which once realised, we're in the process of reducing our footprint at 10SC, but once realised, we'll save in excess of £2.5 million a year. We're also looking at reducing some of our spend with improved contract management across the organisation to get some improvements in there. And also Claire and her team are doing an awful lot of work in TD3 to get more value and reduce where we can some of the IT costs. Again, as part of transformation, we're moving to take some services that historically that we've bought externally and bring them in-house. So there are multiple streams, but I think if you look into the delivery plan, there are specific actions to reduce those non-pay costs as well.
Yeah, so I think just for translation purposes, if you don't mind, Joe, so 10SC is 10 South Colonnade, the main office in London, where the MHRA has been based, and so a conscious decision to reduce the size of the office space that we have. That will be a cost saving in a future year. I think the investment in TD3 is our technology team, effectively. So investment in technology to enable us to become more efficient. Again, we need to invest before we can actually get the benefit from that. So I think actually there's been some really selective, conscious decisions to make investments to make us more efficient for the future. So I think on that point of view, I was certainly assured that those non-pay costs were worthwhile. And so a combination of managing the non-pay costs and managing the exits from the organisation from a people point of view very sensitively has been really, really important to us. So thank you for the question on that. Carly, was there another one or not?
Yes, there is. I think prompted by the discussion on the development of the polio vaccine, we've had a question about what safeguards MHRA can put in place to protect the UK from polio outbreaks.
Oh, now that's a very interesting question. Mark, do you want to start with that? And I might come to Laura or June to add some further flavour.
Certainly. So polio historically was an incredible scourge. We don't really remember what it's like in the 40s, but it was a particularly nasty disease, very easily transmitted by the fecal-oral route, and particularly in childhood would cause extensive paralysis and loss of life. The vaccine program started in the 50s and has been an outstanding public health success, so that polio has been effectively eradicated from most countries. And I think we're now down to 2 or maybe 3 locations where we occasionally see polio outbreaks, and that's partly because it survives in the soil. So with that, we've moved to surveillance in the UK. Now, polio, there is a case that people with polio can actually shed the virus without having any symptoms, but then the virus can be seen in wastewater. And NIBSC collaborates with DEFRA and other partners to survey the wastewater in the UK. And every so often, and it is an extremely rare event, I must say that, but very occasionally, we can detect by modern sequencing techniques the presence of polio again. And this is such an exception, it effectively links down to a single individual who have, for whatever reason, they're expressing again. And that, because we know where the wastewater comes from, we can then very quickly move in and test and then help to locate it. So we control it in the UK predominantly by surveillance. We also have a set of vaccines that have been developed in conjunction with partners and tested in clinical trials. And those vaccines can be used in something called a ring vaccination. So if we can't find the person, you can vaccinate a small number of people to contain it within a geographic site. So we work very much directly with partners under surveillance to keep the country safe.
Great. Okay, I think that's a very comprehensive answer, Mark. June, is there anything else you want to add from your experience?
No, it's a really important example of partnership working with UK HSA, but also being clear with the industry that you know, we are open for early scientific discussion so that we can keep ahead of the curve as we get signs of something coming back to the UK. I think the development of the novel polio vaccine, which is oral serotype 2, is a really important development from Mark's area.
Yeah. Great. Okay, well, thank you very much for that. Carly, I hope we've got another question.
We do have another question, this time on the enforcement strategy, and a question about how much understanding we have of the reason why people are choosing to buy illicit medication online, and if we have any understanding of a potential correlation with rising prescription charges.
Ah, interesting. Okay, Alison, could I maybe come to you first on this one?
Yes, of course. I think motivations probably vary and they're multifactorial. Potentially not being able to access GP appointments, or not being able to, a GP not being willing to prescribe. There is probably an element of drugs of abuse, as well as potentially use outside of a licensed indication. So I think multifactorial, and it's really important we do understand that, because obviously we can't design appropriate prevention measures unless we understand that aspect, and we're continually monitoring it. But yeah, we need to continually monitor and build a really rounded understanding of all of these drivers, and that's definitely something that the Criminal Enforcement Unit are doing and intend to do more of.
Yeah, I think that was a key part of Andy's presentation earlier, wasn't it? About we need to address it, you know, several parts of the you know, the illegal supply of drugs, as you know, both different components of that, as well as maybe understanding the demand. You know, so it'll have to be, you know, clear of what we can do, but actually, I'm sure it is multifactorial in that regard. So I think there's probably more to learn. Is probably the way I would probably summarise that. But I think we recognise the importance of doing that.
That was a really key priority.
Carly, so, yeah, it's critical to keep patients safe. We get that. So, okay, Carly, is that the last one? Just
yes.
We've got as of today?
We've had a couple of others which are not items on today's agenda, so we will go back to people with written responses on those ones, but that's it.
That's great. Well, thank you for doing that. Thank you for everyone who's has made a contribution to the questions. I think, as I said right at the very beginning, actually, because this is a board meeting held in public and is not a public meeting, that's why we're only taking questions on the agenda topics today. But everyone who has taken the trouble to write a question either before the meeting or in the chat function today that wasn't related directly to the agenda, we will give a written response. I think that's our commitment to you as members of the public. So I would just like to bring the meeting to a close by, first of all, thanking our staff in the agency who helped to prepare the papers. Also to thank colleagues from the communications team and the governance teams for their support in preparing for the meeting today. We had a few technical issues, but hopefully that hasn't completely ruined the overall sort of experience of seeing us going through the agenda items today. And just before I leave, I would just like to remind everyone that the purpose of the MHRA is very clearly around to protect and to improve public health. And we'll continue to do that by continuing to enable scientific innovation, by accelerating patient access to new, safe medical products, and of course, strengthening our safety, patient safety and surveillance systems, including the enforcement, which we've been talking around today. So on that, with that in mind, as our core purpose, we'll get back to work, continue to do our very best to protect the public. I'd like to thank you for your attention. I'll now close the meeting and wish you have a good rest of the day. Okay, thanks very much and bye-bye.